Welcome back to the Deep Dive. Today we're doing something really focused. We're diving deep into a set of high-yield revision notes. The idea is to help you quickly get a solid grasp on a specific condition.
Yeah, exactly.
And today that condition is Meconium Aspiration Syndrome, or MAS.
That's the one. And these notes, they're designed to be condensed, packed with the absolute must-know info on MAS, whether you're actually revising for something or maybe you just want to understand it really well quickly. So our mission today is basically to pull out those key nuggets, connect the dots for you, and hopefully make it all stick.
Exactly. We're not just like reading a list. We're going to explore it together, really dig in. We'll look at, what MAS actually is, why it happens, how it happens, who's most at risk,
Right.
what's going on inside the body, how you spot it, the tests, the management.
The whole pathway, prognosis, complications, the lot.
Yeah, the whole thing. We want to get you well-informed efficiently.
And hopefully it'll feel like we're exploring it with you, asking those little questions that help unlock it. We'll flag the so what bits and maybe layer in a few ways to think about it, make it easier to recall later.
Sounds perfect.
Yeah.
Okay, let's get into it then, starting right at the beginning. What is Meconium Aspiration Syndrome? The definition.
Okay, so at its core, MAS happens when a newborn breathes in amniotic fluid that's stained with meconium, gets it into their lungs.
And the big consequence, the immediate problem, is respiratory distress. Because that meconium is physically down there in the trachea, the airways.
Yeah, it causes trouble straight away. And the notes point out it's more common in babies born post-term, after 40 weeks. And there are links to things going on with the mother, too, like high blood pressure, so hypertension, preeclampsia.
Okay.
Infections like chorioamnionitis, and even maternal smoking or substance abuse.
Right, so the formal definition of these notes kind of pulls that together. It says respiratory distress happening shortly after birth. Plus, you see evidence on the chest x-ray, like aspiration pneumonitis, and, there was meconium-stained amniotic fluid, MSAF.
Yeah.
And they make a point of saying severe MAS often goes hand in hand with fetal distress during labor or, asphyxia, lack of oxygen.
Exactly. So if you need a simple way to lock that definition in, maybe think of it like mucky airways syndrome.
Yeah.
Meconium gets in the airway around birth, causes immediate breathing problems. That's the core idea.
Got it. Mucky airway syndrome. Okay.
So next question is why? Why would a baby pass meconium before birth? It's not the usual thing.
Right. Well, the notes say it's typically a response to some kind of stress, fetal distress, hypoxia, lack of oxygen, or maybe certain things happening during labor.
And the source adds a few more things that can up the chances of that meconium passage, kind of building on that stress idea, like placental insufficiency, those maternal conditions we just mentioned, the high blood pressure, preeclampsia, also having too little amniotic fluid, oligohydramnios.
And maternal drug use, like tobacco or cocaine.
Okay, so stress causes the passage, but when does the baby actually breathe it in? The aspiration part.
Good question.
Well, it could happen before birth, in utero, if the baby is gasping because they're distressed, or, and this is probably more common, it happens right after birth, with those first few breaths they take.
So you can sort of see the chain reaction.
Yeah.
Something stresses the baby, they pass meconium into the fluid, and then they breathe that fluid into their lungs. Starts with stress.
Precisely.
Okay, so that's the why. What about the who? Who's more likely to get MAS?
The notes list some key risk factors. Let's lay them out. We've got post-term pregnancy, maternal diabetes, maternal hypertension, fetal distress, and intrauterine growth restriction, IUGR.
Yeah, that's the core list from the notes. Pretty clear. If you want a little memory aid for those, maybe think about a post-mature baby.
P for post-term. M for those maternal conditions like diabetes and hypertension. Distress for fetal distress. And baby. Maybe the I in baby for IUGR.
I see. Yeah, post-mature baby. That could work. Helps group them together.
Just a little hook to hang them on. Okay, now, the pathophysiology. This is where it gets, really interesting and honestly super important for understanding why these babies get so sick and how we treat them. What's the meconium actually doing down there?
Yeah, what's the damage?
So first off, it's thick, sticky stuff. It physically blocks the small airways. That's obstruction.
Like trying to breathe through treacle or thick mud and tiny pipes.
Exactly like that. That's a great visual. So because it's blocking the way out, air can get sucked in past the blockage, but it gets trapped behind it when the baby tries to breathe out.
Ah, so that's air trapping.
That's air trapping, and having that trapped air plus the meconium itself just sitting there really irritates the lung tissue, so you get widespread inflammation.
Okay, so it's not just a physical blockage, it actually causes irritation.
Yes, and more than that, meconium isn't inert. It triggers a chemical reaction in the lung lining. It causes a chemical pneumonitis.
Wow.
And here's a really big one the notes highlight. Meconium can inactivate, basically destroy, surfactant.
Ah, surfactant. That's that soapy stuff that keeps the little air sacs, the alveoli, open.
Yeah.
Right? Reduces the surface tension.
Exactly that. It's essential. And for a newborn whose lungs are just starting out, losing that surfactant function is a massive problem. The air sacs just collapse. Makes breathing and getting oxygen incredibly difficult.
Okay, so let's recap those steps. You've got obstruction, leading to air trapping,
Yep.
which causes inflammation
Right.
and triggers chemical pneumonitis, and crucially, surfactant inactivation.
You got it. If you want a mnemonic for that chain, maybe OAICS, obstruction, air trapping, inflammation, chemical pneumonitis, surfactant inactivation. OAICS.
OAICS. Okay, that maps it out clearly.
Now, important point. When you see a newborn struggling to breathe, MAS is definitely high on the list, especially if there was meconium. Right.
But it's not the only possible cause.
Mhm.
You got to think about other things too. The
Yeah.
differential diagnosis, the notes list the main ones.
Okay, what else should be on our radar?
Well, there's respiratory distress syndrome, RDS, usually in preemies due to lack of surfactant.
Okay, RDS.
Then pneumonia, an infection. Transient tachypnea of the newborn, TTN. That's often called wet lung, just delayed fluid clearance.
ATN, yeah.
And less common, but possible, congenital lung malformations problems with how the lungs actually formed.
So they're all on the list because, well, they all cause breathing problems in newborns.
Exactly.
But the notes stress that what usually helps you lean towards MAS is that history of the meconium-stained fluid,
The staining.
plus the specific clinical picture and what the imaging, like the X-ray, shows. You know, TTN can sometimes look a bit similar on X-ray, but the whole story usually points you one way or the other.
Right, the context is key.
Maybe a way to remember those main breathing differentials.
Yeah.
RPTL, RDS, pneumonia, TTN, lung malformations. RPTL, yeah, that works. Keeps the big ones in mind.
Okay, let's talk numbers. How common is MAS actually? The notes give some UK context. Apparently, it's not tracked nationally there.
No, not specifically.
But the estimates are maybe around 2 to 10% of
So
deliveries.
somewhere in that ballpark, yeah. But what's really crucial here, and the notes make this distinction, is the difference between MAS itself and just having meconium in the fluid.
Okay.
Meconium-stained amniotic fluid, MSF, is way more common, like 4 to 22% of births overall. And that number jumps up quite a bit after 42 weeks gestation.
Wow, so MSF is pretty frequent then.
It is. But, and this is the important bit, and MAS, the actual syndrome, only develops in a fraction of those babies exposed to MSF. Maybe only 3 to 12% of them.
Okay, so that's reassuring. Just seeing meconium doesn't automatically mean the baby will get MAS.
Exactly. And there's some good news in the notes, too. The overall incidence of MAS seems to be decreasing.
Oh, really? Why is that?
Well, they suggest it's likely due to a few things. Fewer babies going really post-term, better monitoring during labor to pick up distress earlier, and maybe more appropriate use of labor induction when needed.
That's positive. Although the notes do mention that globally it's a different picture in some places.
Yes, unfortunately. In developing countries, the incidence, and sadly the mortality rate, tends to be higher. So while we're seeing improvements here, it's still a major issue worldwide.
Right. Good perspective to keep. So if we suspect MAS, what does the baby actually look like? What are the clinical features the notes focus on?
You're looking for those classic signs of newborn respiratory distress. So tachypnea, really fast breathing, grunting, that noise they make trying to keep airways open, chest retractions, sucking in around the ribs and sternum.
Working hard to breathe.
Exactly. And cyanosis, that bluish tinge to the skin from low oxygen. Plus, when you listen to their chest, you might hear decreased breath sounds because things are blocked up.
Okay, those are general distress signs. What points specifically to meconium?
Well, the most obvious thing is seeing thick meconium, or that dark green staining in the amniotic fluid when the baby's born.
Right, you see it.
And sometimes the baby's skin or nails or umbilical cord might actually be stained greenish or bluish green too.
And how does the baby seem overall?
Often they appear quite unwell. They might be limp, floppy, they might have a low APGAR score right at birth, and that breathing pattern can be very fast and labored, or in severe cases, even absent initially. The notes also mention you might see signs of post-maturity, like peeling skin if the baby was overdue. And looking back at the labor, the fetal heart monitor might have shown bradycardia, a slow heart rate, indicating distress before birth.
So putting it all together,
Yeah.
you've got the staining that tells you meconium was there,
Yep.
the respiratory distress showing it's causing a lung problem, and then the baby's general condition, like being limp or having a low APGAR, reflecting that overall stress.
Exactly. Paints a picture. Maybe to remember it, think of a meconium baby, stained fluid skin, distressed breathing appearance, and maybe post-term looking.
Stained, distressed post-term.
Got it. Okay, so we have a baby who looks the part, the history fits. What tests do the notes say we need? What investigations confirm it and help assess how bad it is?
Right, the list starts with blood gas analysis, arterial blood gas, or ABG.
Crucial.
Yeah, it tells you about oxygen, CO2 levels, and the pH checks how bad the respiratory failure is and if there's acidosis.
Then serum electrolytes. These are important for checking kidney function and also looking for things like SIADH, syndrome of inappropriate ADH secretion, which can happen in stressed babies.
Okay, and a full blood count, FBC.
Yeah, helps rule out infection as a cause or contributor and can give clues about other stresses the baby experienced.
And then the big one for diagnosis, I guess, is the chest x-ray, the CXR.
Absolutely central. That's where you look for the signs of the aspiration pneumonitis. You might see patchy infiltrates, maybe some streaky densities, sometimes areas of hyperinflation from that air trapping.
The notes also mention lung ultrasound.
Yes, as a quicker, possibly cheaper bedside imaging option that can also show signs of lung problems.
What about brain imaging, like ultrasound or MRI?
The notes are clear. That's only needed if the baby is showing neurological signs like seizures. It's looking for brain injury from hypoxia.
Gotcha. And an ECG, electrocardiogram.
That's on the list too. Helps evaluate the heart, specifically looking for signs of pulmonary hypertension, high pressure in the lung arteries, which is a really common and serious complication of MAS.
Right. So if you got an exam question, say, about a baby with suspected MAS, asking for a key diagnostic test, the CXR showing aspiration pneumonitis would likely be the answer based on these notes.
Yeah, that's usually the one that visually confirms the lung issue.
Okay. So for remembering the main tests, maybe baby's ABCs and more, A for arterial blood gas, B for bloods, FBC electrolytes, C for CXR or ultrasound,
Like that.
E for ECG, and brain imaging only if neurosigns.
Babies, ABCs, and E. That works.
Okay, management. We figured out it's MAS. What do we actually do about it? Sounds like it needs a pretty active approach based on the notes.
It absolutely does. The immediate steps are critical. Right at birth, clear the airway, provide respiratory support that might just be oxygen, or it could mean CPAP, or even full mechanical ventilation.
Okay.
Give antibiotics if you suspect an infection might also be going on, and just general supportive care, keeping them warm, managing fluids, etc.
And the notes really emphasize admitting these babies to the NICU, the neonatal intensive care unit, if they have respiratory distress.
Yes, strongly recommended. Because they can go downhill fast. They need really close monitoring of their oxygen levels, blood pressure, correcting metabolic issues like acidosis, constant vigilance.
Makes sense.
Yeah.
Okay, digging into the specific treatments mentioned. Airway suctioning first.
Right. There's a nice guideline mentioned in the notes. It suggests considering suctioning the upper airway, like the mouth and nose, right after the baby's shoulders are delivered if the meconium is thick.
Okay, just considering it then.
Yeah. But if the baby comes out and is clearly depressed, floppy, not breathing well, then trained staff should perform laryngoscopy, look directly at the vocal cords, and suction the trachea below the cords. That needs proper neonatal life support training.
Right, more invasive. What about oxygenation?
The goal is to keep their oxygen saturation levels pretty high, like 95 to 98%. The notes mention a preference for using nasal CPAP, that continuous positive airway pressure, over just giving oxygen by a mask or nasal prongs. The idea is CPAP might help avoid needing full ventilation.
Trying to keep them off the ventilator if possible.
Exactly. But if CPAP isn't enough, then mechanical ventilation is needed. And sometimes with ventilation, they can develop a pneumothorax, an air leak, which might require putting in a chest drain.
Okay. What about more advanced stuff for really sick babies?
Yeah, the notes cover those too. HFOV, high-frequency oscillatory ventilation, is a specialized type of ventilation. Then there's inhaled nitric oxide, INO. Its main job is to treat persistent pulmonary hypertension, PPHN, that complication we mentioned, It helps relax the blood vessels in the lungs and can help open airways too.
Ah, okay. So it targets the PPHN.
Correct. And enteral sildenafil, given via a feeding tube, is also mentioned as another way to treat PPHN associated with MAS.
And surfactant replacement, we talked about how meconium inactivates it.
Exactly. So it makes sense that giving replacement surfactant can really help. The notes say it often rapidly improves oxygenation.
It seems logical.
And in severe MAS, giving surfactant either as a quick push, bolus, or a slower infusion can actually reduce the chances of needing the ultimate support, which is ECMO.
Okay, that's a key intervention then. What about anti-inflammatory treatments? Steroids?
They get a mention. The idea is they could counteract the inflammation caused by the meconium, but the notes are quite clear here. While steroids have shown some promise in lab studies, they are not currently part of routine treatment for MAS in practice. Still experimental in this context.
Got it. Not standard care yet. And ECMO.
Extracorporeal membrane oxygenation.
Yeah.
That's really the last resort for babies who are failing despite maximum ventilation and other therapies. It's the artificial lung machine.
Okay. And finally, antibiotics.
Yeah, the notes touch on this. Giving antibiotics routinely, just in case, prophylactically, hasn't been shown to reduce MAS itself, but you might still use them if there are other reasons to suspect sepsis. And overall, constant monitoring and reassessment is key throughout all of this.
Wow, okay, that's a lot in management. It's like a step-up approach.
It really is. From basic airway and oxygen, escalating through CPAP, ventilation, then the specific treatments like surfactant and INO, and finally ECMO if needed.
Maybe for remembering the management phases. Think initial airway, oxygen support, then respiratory escalation, CPAP, vent, HFOV, INO, then specific surfactant, and complications rescue, PPHN drugs, ECMO.
Yeah, breaking it down like that helps structure it. Initial respiratory escalation, specifics, rescue. That covers the main parts. All right, so after all that intensive care, what's the outlook? The prognosis?
Well, the notes say it really varies depending on how severe the MAS was in the first place.
Which makes sense.
The good news, generally, is that most babies who get MAS, if they get the right management promptly, actually recover without long-term problems.
That is good news.
But complications can still happen, and the notes list some important ones to be aware of.
Yeah, what are the main risks?
Pulmonary hypertension, which can stick around as persistent pulmonary hypertension of the newborn, PPHN.
We mentioned that, yeah.
Pneumothorax, that air leak in the chest, lung infections developing on top of it all, and potentially long-term respiratory issues for some kids.
Okay. And how does recovery usually look?
The notes say mild cases might resolve in just, say, 2 to 4 days, though the fast breathing might linger a bit. Usually they bounce back well, but prolonged lung damage is possible, especially if the baby needed mechanical ventilation that usually signals a more severe case.
And what about the brain? Any neurological impact mentioned?
Yes, critically. If the baby suffered significant hypoxia, lack of oxygen because of the severe MAS, that can lead to long-term neurological damage. The notes specifically link MAS to neonatal seizures right after birth, and potentially to chronic seizure disorders later in life.
That's serious. And mortality. Does it happen?
Sadly, yes. The rates vary. The source quotes about 1.2% in the U.S., but notes it's higher in developing countries. And they list risk factors for mortality. Poor heart function, myocardial dysfunction, low birth weight, and how much oxygen the baby needed right at the start. Basically, the sicker they are initially, the higher the risk.
Makes sense. Anything else on long-term outcomes?
There's an interesting point about neurodevelopment. The notes mention that elevated levels of a specific liver enzyme, AST, aspartate aminotransferase, seem to be linked with poorer neurodevelopmental outcomes later on in children who had MAS.
Huh, that's specific. AST levels.
Yeah. So understanding these potential complications, the lung issues, the neurological risks, the mortality factors, it's really important for revision, right? It shows why MAS needs to be taken so seriously and managed aggressively.
Absolutely. It's the full picture.
Maybe for remembering the main complications, think lung problems. L for lung infections, U for unstable breathing or PPHN, N for neurological damage, G for gas leaks, pneumothorax, and maybe P for persistent respiratory issues.
Lung problems. Yeah, that captures the main areas of concern pretty well.
So let's wrap this up. We've done a pretty focused deep dive into meconium aspiration syndrome, pulling out what seemed like the key bits from these revision notes. Covered the definition, causes, risks, pathophysiology.
Differentials, epidemiology, presentation, tests, management, and finally prognosis and complications. The whole journey.
Yeah. And the goal, really, was to give you a clear, structured way to think about MAS, hopefully helping that knowledge stick, whether it's for revision or just understanding.
We tried to hit those essential points that revision notes like these typically focus on.
For me, a couple of things really stood out. That clear difference between just having MSF and actually developing MAS,
Yeah, that's key.
and really getting my head around that pathophysiology, chain, the obstruction, air trapping, inflammation, chemical irritation, and especially the surfactant inactivation. It feels like understanding that makes all the management steps click into place.
I agree. Connecting the what's happening to the what we do about it is crucial. And maybe a final thought for you to mull over based on what we discussed from the notes.
Okay.
Given that the incidence of MAS is decreasing, at least in some parts of the world, what specific future steps, maybe wider use of certain monitoring in labor or perhaps new interventions, might be most effective in pushing that rate down even further, especially thinking globally in places where MAS is still a much bigger problem?
Yeah. How do we get those improvements everywhere? Good question to ponder. Well, thank you for joining us for this deep dive into MAS. We hope breaking down these notes has been useful for you.
Hope it helps solidify things.
And if you are looking for revision notes like the ones we've been discussing today, or similar resources, you might find pathomsra.com useful. That's PASSTHEMSRA.com.
And it's always worth remembering there are free resources out there too, often covering similar ground. Check out freemsra.com, FREMSRA.com.
Great. We'll be back soon with another deep dive. Until then, keep learning.